Okay, I chose to do my recommendation on the Braden scale for pressure ulcer reduction. I am Sydney Snyder. So the problem is pressure ulcers. In the U.S., 2.5 million people will acquire a pressure sore every year. And these pressure ulcers will affect the quality of life for patients. They can cause pain and put patient at risk for infection as well as suffering. May cause sadness or even depression because pressure ulcers may limit them from doing what they could do previously. Um, Sepsis, cellulitis, bone, and joint infections, and certain types of squamous cell carcinoma are complications of pressure ulcers, according to the Mayo Foundation for Medical Education and Research. So pressure ulcers can lead to increased healthcare and healthcare costs. You're going to have increased healthcare costs due to the treatment of the pressure ulcers and also readmissions for the complications stated previously. So my PICO question is, in bedridden patients, how does the use of the Braden scale compared with a basic nursing skin assessment affect the rate of patients with a break in skin integrity over a 6-month period? I'm just going to kind of discuss the Braden scale real quick here. So it was created by Barbara Braden and Nancy Bergstrom in 1988. It is an instrument to assess pressure ulcer risk. So it's not going to actually reduce pressure ulcers, it's just going to tell you who's at risk so you can intervene and perform preventative measures, thus then reducing pressure ulcers. It includes 6 subscales with score ranging from 6 to 23. The lower the score, the more at risk you are for acquiring a pressure ulcer. And for the purpose of this recommendation, we will be using a cutoff score of 17. So that means if their score is 17 or below, preventative measures will need to be initiated. So the 6 subscales include sensory perception. Are they able to feel moisture, activity level, mobility, are they able to move, nutrition, are they malnourished, and friction and shear. So the nurse will go through each subscale and choose a number, and it will tell you what each number means, and the nurse will choose it based on her judgment and obtain a total score. So the evidence-based practice theory used was the Johns Hopkins Nursing Evidence-Based Practice Model. This model allows nurses to convert evidence to clinical, administrative, and educational use. So the reason this was used is because the Braden scale is used in clinical practice by bedside nurses, so I thought a model that included their input and opinion would be beneficial. And here is just some review of the literature. A study done by Van de Bosch, Montoyer, Satwicks, Durkee, Leonard, and Moylan Lewis in 1996 compared nurses' judgment to the Braden scale. And it found Braden scale scores different for people with and without pressure ulcers, and the Braden scale was significant for identifying pressure ulcer risk for those that acquired a pressure sore and those that did not. Nurses' clinical judgment in predicting pressure ulcer development was correct 51.7% of the time, but this was not significant. So level of evidence, it was a level 2 because it was a randomized controlled trial. Subjects were their own control, but it was unknown if the order of skin assessments or Braden scale was randomized. So this is going to affect the quality of the evidence of this study right here. The study only took place over 2 weeks. In my opinion, I don't think that's long enough to collect enough data to make a great decision. The Braden scale did show to be reliable from this article, and then subjects were matched perfectly because they were their own control, so that helps with the quality of the evidence there. Then another study was reviewed. It was a meta-analysis on predictability of risk assessment scales and nurses' judgment, and it found that the Braden scale had a good predictive capacity, 3.5 to 5.5 higher risk of developing a pressure ulcer after the cutoff score. So that was the score of 7, like for example, the score of 17 that we will use for this recommendation. The Braden scale was able to predict it 3.5 to 5.5 times higher risk. A nurse's judgment alone was found to not be a good risk identifier for pressure ulcers. And this was a level 1 level of evidence because it's a meta-analysis. The inclusion criteria for this meta-analysis did not specify that the studies had to be randomized controlled trials, so that affects the quality of evidence. Relative risk was used as a predictive indicator for pressure ulcer risk. The Braden scale was able to detect those at risk 4.78 times more than those not at risk, and clinical judgment was able to detect 1.8 times more. The Braden scale was not significant, and clinical judgment was only significant if they used an alpha of 0.10. So that would also affect the quality of the evidence as well. So more review of the literature. A study done by De Souza, Santos, Irie, and Oguri examined the use of Braden scale with long-term care patients and found that the Braden scale had a high validity of detecting those at risk for pressure ulcers, using a score of 17 to determine those at risk. So 17 was their cutoff score. The area under the receiving operator curve was 0.81, and that's how they determined that the Braden scale had a high validity of detecting those at risk. Another study done by Yap, Rapp, Kennerly, Krohn, and Bergstrom in 2015 collected data on the Braden scale and a tissue tolerance test, and it displayed that the use of the Braden scale to identify pressure ulcer risk helps nurses make preventative decisions. So if the person is at risk, the nurse will know she needs to intervene and intervene with an intervention to prevent pressure ulcers with this person. Another study displayed that Braden scale had high sensitivity and low specificity, and stated it was not a good pressure ulcer risk instrument. There were some studies that were contradicting to my recommendation, like this one, but to combat these, obviously the proof of the Braden scale is not perfect, and what instrument is completely perfect. So to combat this, a nurse can use her own clinical judgment as well on top of the Braden scale to assess risk. Internal evidence and patient preference. The Braden scale is already used by many hospitals, so it has good internal evidence. It's already in use. And I will need to compare pressure ulcer rates before and after Braden scale implementation. Patient preference. So the Braden scale is a quick, non-invasive assessment. The patient may not even know you're doing it. You're just going to do it along with your head-to-toe assessment, so the patient may have no idea. If a patient is at risk, preventative measures can be initiated to prevent pressure ulcers, and this will decrease pain and suffering, also maybe improve mental health. It's going to decrease healthcare costs for the patient, and obviously healthcare costs for the hospital, because if they're preventing that pressure ulcer, they're not going to have the readmissions and the cost of treatment. Patients that are not at risk, costly preventative measures are not implemented. So if the Braden scale score is higher than 17, preventative measures aren't implemented, and the patient will not get a pressure ulcer, and this will save money because the patient will not have to pay for the preventative measures implemented. So my recommendation is use of the Braden scale with a nursing assessment at least once every shift, and you'll just do it along with your head-to-toe assessment. Clinical judgment should still be used in coordination with the Braden scale. So the literature described in previous slides gives evidence that the Braden scale is beneficial in assessing risk for those with pressure ulcers. So the stakeholders for this recommendation are patients, nurses, nurse managers, quality improvement team, electronic health records department, and the information technology department. Patients are stakeholders because they will be the ones that the Braden scale will be used on to identify if they are at risk. Nurses will be necessary because they are the ones utilizing the Braden scale. Nurse managers will oversee the nurses utilizing the Braden scale and be able to discuss with the nurse any questions they have, so these questions can then be forwarded onto the quality improvement team. The quality improvement team is also involved with boosting quality of healthcare, so this recommendation is going to decrease pressure ulcer rates, so that is improving healthcare, so they will be a stakeholder as well. It will also be necessary to get support from the electronic health records department, because we will need to look at electronic health records to see pressure ulcer rates prior to implementation of the Braden scale, and then we will also use the we will also use the electronic medical records to view pressure ulcer rates and Braden scale scores throughout the implementation of the recommendation. And the Information Technology Department will be important to incorporate the Braden scale into the electronic medical record under the assessment tab. So the implementation group will include nurses, those involved with quality improvement in the hospital, and also the electronic records department, as I said previously. So data can be obtained on pressure ulcer rates in the hospital prior to implementation of this project, so comparisons can be made and justify the recommendation of using the Braden scale. So for implementation in practice, the Braden scale will benefit patients by decreasing pressure ulcer rates. So this will decrease hospital expenditure because pressure ulcers are prevented. Hospitals will not have to pay for treatments and readmissions due to pressure ulcers. Nurses will also benefit because it is a quick assessment that can provide good outcomes for their patients and eliminate unnecessary preventative measures if not necessary for a particular patient. So necessary resources are approval from the IRB, approval to use the Braden scale, electronic medical records, and then nurses to utilize the Braden scale. Monetary requirements will just be salary for employees, but they would be paid that anyway because it's just going to be during their normal shiftly hours that they will conduct this on patients. So we will need to send an application for IRB review, and that will hopefully be approved. The hospital must request permission for the Braden scale, and here's a website here they can go to do that. The leader of the quality improvement team will contact the nurse managers on each unit and inform them of the implementation date of the Braden scale a month prior to the implementation. So this will kind of allow the nurse managers to introduce it or just kind of discuss it with their employees and tell them it will be coming. Then 2 weeks prior to the implementation date, each unit will have a Braden scale educational session for all nurses to review its purpose, benefits, risks, and how to use it, and any questions can be answered. And then during this time, an informational sheet on the Braden scale will be given to each patient on admission, kind of explaining the Braden scale, and this will be given to each patient on admission throughout the whole implementation process. So the purpose is to identify those patients at risk for pressure ulcers so preventative measures can be initiated, thus preventing pressure ulcers. Electronic health records will be used to collect pressure ulcer rates, and if preventative measures were implemented on all units and hospitals over the past 2 years prior to implementation of the Braden scale, and this data will all be placed into a table for easy viewing. The Information Technology Department will be necessary to incorporate the Braden scale into electronic medical record under the assessment tab. And once the Braden scale is implemented, every month the quality improvement team will review electronic medical records for pressure ulcer rates on each unit and whether preventative measures were initiated for the Braden scale score less than 17 or less. Demographic data that will be collected is age, gender, Braden scale score, and subscores, reason for admission to the hospital, and comorbidities, and this will all be included in a table so for easy viewing and justification after the recommendation process. The rates of patient with a break in skin integrity and diagnosis of a pressure ulcer development during the hospital stay will be monitored. The project will be considered successful if pressure ulcer rates are significantly reduced over a year of trial. So barriers to implementation are staff being resistant to new ideas, and I think mainly this would stem from staff not wanting to incorporate this because they're afraid of the time it may take, because their nurses' schedules are busy. So we just need to emphasize at our educational sessions the ease of use and the benefits for the patients, and just emphasize how it's a quick assessment. Facilitators, the Braden scale is a short assessment that isn't time consuming, thus benefiting the nurse. During educational sessions, we can also encourage use by describing benefits and ease of use. The quality improvement team will meet with the nurse manager from each unit every month to answer questions and see what the nurses and patients think of it and address concerns, and an email will be given out that the nurse manager can contact us if they have questions before the monthly meetings. Evaluation of the project. The quality improvement team will evaluate the pressure ulcer rates each month, and information will be emailed out to the hospital employees displaying what was found. A year after project implementation, the team will compare pressure ulcer rates before and after Braden scale implementation, and if rates have significantly improved, a policy will be initiated for the Braden scale use throughout the hospital. Once the project is successful, the information can be disseminated to other hospitals in the area. And that is my recommendation, and here are my references.